Welcome. Thank you for standing by. At this time, all participants are in listen-only mode. After the presentation, we will conduct a question-and-answer session. To ask a question, you may press star and then 1. This call is being recorded. If you have any objections, you may disconnect at this point. I will turn the meeting over to Ms. Katie Watkins. Ma'am, you may begin.
Thank you. Good afternoon and welcome to today's Midwest Affiliate Target Stroke webinar. For those of you unfamiliar with Target Stroke, it is the American Heart Association, American Stroke Association's initiative to decrease door-to-needle times for TPA patients with a goal of less than 60 minutes. Today, you will hear best practice strategies from 3 speakers across the Midwest on how they have implemented Target Stroke within their hospitals and communities. Before I introduce our first speaker, I would like to draw your attention to 2 housekeeping items. At the top right hand of your screen, you will see an icon with 3 sheets of paper. By clicking on this icon, you will be able to download slides and resources that are shared on today's call. Questions can be asked in 2 ways. Questions can be submitted electronically by clicking on the Q&A tab at the top left hand of your screen. Questions that are typed in can be typed in during any point in the presentation. Questions can also be submitted verbally. We will hold all verbal questions until the end of the presentation this afternoon and then allow the phone lines to be opened up. With that, I would like to introduce our first speaker, Ms. Kathleen ONeill. Kathleen is the Midwest Affiliate Regional Vice President of Quality and System Improvements based in our Chicago office. She is here today to speak to an exciting Chicago-based Target Stroke initiative that has recently earned a publication in the Journal of the American Medical Association. Kathleen, I will now turn the presentation over to you.
Thank you, Katie. I'm very happy to present a brief overview of the published manuscript, Pre-Hospital Triage to Primary Stroke Centers and Rate of Stroke Thrombolysis. This manuscript was under the expertise and leadership of Dr. Sean Prabhakaran of Northwestern Memorial Hospital, myself, Leslie Stein-Spencer, who is the Manager of Medical Administration and Regulatory Compliance at Chicago Fire Department, Dr. Jim Walter, one of 4 EMS medical directors for the City of Chicago, who has recently stepped down and is currently an emergency room physician at University of Chicago Hospitals, and well-renowned stroke neurologist Dr. Mark Alberts, formerly of Northwestern Memorial Hospital and now Vice Chair Clinical Affairs and Professor of Neurology and Neurotherapeutics at UT Southwest in Dallas. So let me start by just saying that the manuscript is available. I've included the link here on the slide. It does require a subscription. If you do not have access to a subscription, please feel free to contact your QI director for a copy. Let me provide just a brief background on our Illinois legislation. In 2009, House Bill 2244 allowed the creation of regional stroke systems of care throughout our state. The legislation allows our Illinois Department of Public Health to designate specialty stroke centers, and it directs EMS to transport suspected stroke patients to primary stroke centers or emergent stroke-ready hospitals. This allows for flexibility whether we are serving the 3 million plus citizens of Chicago, Region 11, or our smaller, more rural regions downstate. For example, on this slide, you'll see that Region 5, we have 1 primary stroke center serving this entire region. The legislation also created the Regional Stroke Advisory Subcommittees. There are 11 of them, 1 in each of our 11 regions, EMS regions of the state. And the Chicago Regional Stroke Advisory Subcommittee drafted and implemented the state's first stroke transport protocol, which is really the basis for this manuscript analysis. So very briefly, the objective of the manuscript was to evaluate the impact that the citywide policy recommending pre-hospital triage of suspected strokes to the nearest primary stroke center had on TPA administration in Chicago. We did this by analyzing our Get With the Guidelines stroke registry data from 10 of our primary stroke centers that were implementing Get With The Guidelines at that time. We did this 6 months, an analysis 6 months prior to our implementing our transport protocol and our system of care, and then 6 months after. What we found was that the implementation of this triage policy resulted in significant improvement in EMS use, in pre-notification, and it more than doubled TPA at our primary stroke centers in the city. As you can see, when we started, we had a considerable opportunity for improvement, and we're very pleased to say that not only have we continued this upward trend, we are being able to sustain it, and now we are in our second year. My role in this project was really to work and to support and help convene the regional level stroke advisory subcommittee. It was also to provide education and resources to promote evidence-based science supporting the systems development, and to help make sure that all of the multidisciplinary participants of this committee were informed of the AHA science. And the regional stroke advisory subcommittees were made up of emergency room physicians, neurologists, administrators from both primary stroke centers and non-primary stroke centers, EMS, Chicago Fire Department, as well as our private ambulance. It also included representation by our hospital stroke coordinators, our Get With The Guideline abstractors, and folks that did data entry. So it was very, very all-inclusive. We utilized the Get With The Guideline stroke registry data to provide information to support these important decisions that we were making, and to support performance improvement activities. Keep in mind, this data was not used, was not meant to be punitive in any way, shape, or form. In my role, I also share these best practices throughout the state. Although we did create this stroke transport protocol to serve 3 million citizens, it can be tweaked so that it can be a template for use in other regions of our state, regardless of the number of primary stroke centers or the number of emergent stroke-ready hospitals. I was also involved in the recognition both of our hospitals and our EMS providers, which is extremely important. Feedback and recognition really have helped us to sustain what we're doing. I also work very hard to provide whatever resources and support I can to sustain this model and help it to grow. Updates and next steps. Since this manuscript has been published, we have updated our stroke transport protocol, and we have now required that hospitals use a standardized measurement tool, and that has 14 out of our 15 hospitals are up and running with Get With The Guidelines and participate in what we call a super user account, which allows aggregate system data to be pulled and shared. Again, this data is aggregate and de-identified, and it is not meant in any way to be punitive, but only to support our performance improvement efforts as a system of care in Illinois. We do review data on a monthly basis. That data is shared with EMS, hospitals, and all of the members of the RSAS group on a monthly call. We now have 15 hospitals that are working on a collaborative and funded door-to-needle initiative using target stroke best practices and resources. And stay tuned for more information on that. We have submitted an abstract to the AHA's International Stroke Conference and hope to be selected to share more about the outcomes of this collaborative initiative. We are very excited that we are able to leverage the STEMI transport protocol in Chicago with their system-wide implementation of the LifePak 12 and we will, we hope to add the stroke pre-notification alert, which is a feature of the LifePak 12, and to enhance even more and better pre-notification for our stroke centers in Chicago. We've also piloted some data matching between our EMS data that's collected by Chicago Fire Department using the SafetyPad software, as well as the data from our Get With the Guideline hospitals. We're using this for performance improvement. We're also mapping some of this data to help us target where we should focus community education efforts in our city. Okay, so I think we're going to hold questions till the very end, but I would like to now turn this over to our Quality and Systems Improvement Director in the Dakotas, Pamela Mode, to introduce our first hospital speaker. Pam?
Thank you, Kathleen. Good afternoon, everybody. I'd like to thank Dr. Ann Hopf and Geralyn Alexander from the Trinity Health System in Minot, North Dakota, for presenting on this webinar. Dr. Ann Hopf is board certified in emergency medicine. Dr. Hopf received her Bachelor of Science degree in biology from the University of Mary in Bismarck and her medical degree from the University of North Dakota. She's conducted considerable research and education into the best methods for treating stroke in an emergency department setting. Dr. Hopf is certified in advanced trauma, cardiac and pediatric life support, as well as the fundamentals of critical care surgery. She's a member of the American College of Emergency Physicians. Dr. Hopf is on multiple interdisciplinary committees, including Trinity Health Stroke Committee, where she's the co-medical director and leads the team in education of pre-hospital, nursing, and physician staff on acute stroke recognition and treatment, protocol development, and preparation for the Joint Commission Primary Stroke Center certification. Geralyn Alexander, RN, has been with Trinity Health Stroke Coordinator since 2011. She graduated nursing school in 1992, and she's experienced in ER, ICU, and flight nursing. She's a member of the North Dakota Participating Hospital Advisory Committee for Stroke and is active in the North Dakota Department of Health Stroke System of Care Registry, consisting of 6 tertiary care facilities and 26 critical access hospitals. Trinity Health is a 250-bed tertiary hospital in North Dakota situated in the Northwest region. They have achieved Get With the Guideline Stroke Silver Award status and became the 1,000th hospital in the nation to become a certified primary stroke center in November of 2012. I'd like to thank Dr. Hopf and Geralyn for being here, and Geralyn, I will turn it over to you.
Thanks, Pam, and thanks for outing how old I am with my year of graduation. We're very pleased to be here, Dr. Hopf and I. We're going to kind of review pretty quickly a little bit about our facility and kind of the struggles and challenges we've had in our rural setting. So as Pam said, we are a 250-bed facility. We're located in northwest North Dakota. The region that we serve also has 11 critical access facilities, and some of these facilities have 2 beds in their whole entire facility. So very, very rural region. However, we've had some changes. That's where we're located, and as Pam said, we have 6 tertiary centers, and so kind of where the dark gray circles are is kind of encircling the larger tertiary centers. So you can see there's a lot of, I guess we could call it frontier area in our state that is well outside of, opportunity for, acute treatment of stroke. And so when you look at the maps and then you kind of start looking at what's going on in our region, our stroke program actually started prior to 2011, but that's when I started as the coordinator and kind of got the program up and rolling. And so as we are beginning our program rollout, we actually experienced a devastating flood to our community that occurred at the end of June, July of 2011. And this was a very devastating and impactful challenge to our community. It basically split our community in half. We had the north end of town and the south end of town and had a lot of challenges with getting patients to our facility based upon the location of the flood. So those are some pictures The bottom left-hand corner is actually one of the middle schools in our community, and we'd had a previous flood back in 1969, and that school was flooded at that time, and so they diked. You can kind of see a little bit of the ring dike going around the school, and it was inundated with flood water again in 2011. And so we've had a very devastating event to our community. And during this, and I tried to find pictures, but I couldn't find any, but we actually had to evacuate our nursing facility, our long-term care facility in our community. And so a lot of these patients were divvied out to those rural skilled nursing facilities. We actually had to go on very limited, allowing limited patients to come to our facility because of the impact with the water systems and such in our community. And so it was just a very devastating thing that happened to our community shortly after we started our stroke program. So a lot of the things that we had in plan that we were going to be implementing had to be delayed due to the flood. Actually, then also with the flood, we lost a lot of housing, as you could tell by the pictures. And then also, when out west of our community, we have a very expansive oil boom going on. And so we have a major, major population boom that's occurring to the west of us. And so you can see we have a lot of traffic. We have a lot of people moving here from throughout the country that have traveled here for work because of our economy. And the top right-hand picture I thought was very interesting because it kind of shows the light of our oil exploration that's going on. So that where it says the Bakken and kind of that orange big glow, that is actually the oil field. And as you can tell, we can't even harness the natural gas, so they're flaring it off. And so we have it's very lit up in this region of the country. And so that's also presented a very large challenge to our community hospital here in Minot. So with that, we have issues with housing, our increased population, wages. People that are working here at the hospital can go out into the oil field and make a whole lot more money. So we have a lot of shortages with our healthcare providers. With the critical access hospitals, they're very much in dire need of providers and workers. They would only see maybe 2 patients a day in their tiny, small ERs, and now they're booming. They're seeing 20 patients a day, and they're transporting a lot of patients. And so this has also put a strain on our EMS providers out in the rural setting because most of them are volunteer, want to help out their community, and they're getting inundated with taking patients to Minot daily, if not multiple trips during the day. So we have a lot of challenges here in our region of the state. As Pam said, we did receive the Silver Award for Get With the Guidelines Stroke, and then we also were the 1,000th Primary Stroke Center certified, and that occurred last November. So you can see we started this process in May of 2011, and we finally achieved our Primary Stroke Center certification in November. So it was a long process, but we got there. So this is kind of a graph of our historic data as far as door of IVTPA within 60 minutes, and you can see baseline, we were never achieving that. Same thing in 2011, and now we're starting to see improvement. And we're going to talk about kind of what we've done and kind of some of the challenge that we're still seeing here at Trinity. So some of our challenges. I kind of like to talk about as being a kind of an in-between bigger facility. We've got our critical access hospitals that have very limited testing. Some of our critical access hospitals don't even have a CT scanner. And so we are able to actually do the CT, and we also have the ability to do MRI and MRA. And so, now we're at the point of do we do all that testing prior to giving TPA? And so we have that availability. Once we have that ability, we're able to diagnose those patients with a true confirmed stroke by MRA. And so the physicians really like to have that definitive answer because that tells them for sure they're having a stroke, but then you have that delay of time going from CT and then into an MR. And so that's also presented a challenge. We also have kind of a no sense of urgency issue. We kind of have extreme ends of the spectrum. We have an older population. I can tell you in the last couple of weeks alone, we've seen 92, 95, 98-year-olds coming in with stroke. And so we definitely see an older population, but then we also see a very much younger population with the oil boom. We're seeing a lot of workers in their 30s, 40s, 50s that are coming in with stroke symptoms as well. Physician awareness. As I said, we have kind of that provider shortage that goes on, so we do use locum tenens, and also in the critical access hospitals, they use a lot of locum tenens. So, even awareness within those critical access facilities of what their capabilities are. We've had patients where the physician didn't even know they had TPA to give. And so, really that awareness piece is a challenge. Also delay in presentation, and that's nothing new across the country. Patients wait. We see an extreme on that end. We have patients that sit at home for 2 or 3 days prior to coming in. I think with our genetic makeup and our culture here, we have a lot of older population of Germans and Norwegians who don't want to bother anybody, so they'll just wait at home for 2 days before they come in, and then they have trouble walking or swallowing. And we actually had a patient that Dr. Hopf took care of that waited 12 days prior to coming in for their stroke symptoms. And then we have that lack of frequency of giving TPA. It's not something that we're giving on a daily basis, and so that presents a challenge in the fact that the nursing staff says, oh, I've never given this before, how do I give it? So, those are all challenges that we see on an almost daily basis here at our facility. So as far as overcoming some of those challenges, I'm very excited that Dr. Hopf has recently become co-medical director of our program. She has strong medical leadership, and our other medical director, who's Dr. Korlar, also, they believe the quicker we can give this medication, the better the outcomes. They believe that. That's their mantra. And so, we're really looking at fine-tuning our processes and really trying to get that medication to the patient as quickly as possible. We're looking at that definitive testing, that MRI, MRA, that can wait. We need to give the medication first. Like I said, we're streamlining our processes and then just educate the staff, the providers that, we need to get this done. And then also with the community, we're really going out and stressing the fast and calling 911 and coming to the hospital as quickly as possible. So I do have a quick case presentation I want to share with everybody. We had a 69-year-old male that had sudden onset right-sided weakness, facial droop, and aphasia that started at 7:30 at night. This patient was approximately 1 hour and 20 minutes outside of Minot. The ambulance was dispatched at 8 o'clock, and this was one of those BLS volunteer services that went and picked the patient up. And along the way, we have some paramedics that are in some of our critical access hospitals that will hop into the back of these BLS ambulances. And so when they picked up this paramedic, he took one look at the patient and said, keep driving. Do not stop at that critical access hospital. And so they kept on driving. They got to our facility a little bit after 10 o'clock. The patient went to CT. They did a finger stick glucose. The patient was eligible for thrombolytics and received that medication by 10:30. So he made it within the 3-hour window and then also within the 60 minutes. The patient went to ICU. He was discharged to a rehab facility, which is connected with Trinity, on day 3 of his hospitalization, and he was home 12 days post-stroke, and he had a very, very positive, good outcome. So that really made the staff very excited and happy. And so the positive outcome, obviously for the patients, is huge. That's what we're looking for with this Target Stroke Initiative, and then also for the family. Our whole facility knew about how quickly we gave the medication, which was kind of neat. I had an ICU nurse that I know, and she came up and she said, I heard they just whipped that guy right into CT, and so, it really became a very positive thing for our entire facility. And the staff really had a sense of accomplishment and kind of that beat that attitude. They see if you can do any better than we did. And so I think that also helps with getting the excitement of the good outcome and then that they did it so well. So as far as our goals, our consistency of giving patients TPA within the 60 minutes, we're really setting our goal of really looking at that and pushing hard. We're really educating our staff so we have that level of comfort. Like I said, we're really pushing the public education to not delay presenting and then to continue to streamline our process. Look at each case that we run through the ER as a stroke alert and really trying to learn from each one is how can we do it better, how can we shave off more time. And that's all I have. I'll turn it back over to the leader. Thank you.
Thank you, Geralyn. It is now my pleasure to introduce our final speaker of the day, Ms. Bozell. Karen is the Stroke Program Coordinator for Abbott Northwestern Hospital. Abbott is the largest hospital in the Twin Cities. It serves over 200,000 patients and families from the Twin Cities and the Midwest each year. Karen is responsible for the quality measures of the stroke program and the Joint Commission Primary Stroke Certification. She manages the stroke program details to ensure quality of care across the continuum for the stroke population. Her background includes trauma and stroke program management, emergency department, critical care, and flight nursing direct patient care. An Allina Health employee since 2000, Karen has worked at Abbott Northwestern Hospital since 2011. Karen, the floor is yours.
Thank you, everyone. So I'm going to present a little bit about Abbott Northwestern, as you heard, and more of the metropolitan perspective of the Target Stroke Initiative. So a brief introduction, Abbott Northwestern Hospital is one of 11 hospitals in the Allina Health system. You can see our statistics there on the slide. We have about 5,000 employees here, and our ED last year's average was almost 50,000 visits for our ED. So we're a pretty busy facility. This is actually our stroke statistics in 2012. We're well into the 500 for our volumes for stroke. But midway through the slide, you'll see that in 2012, we treated 35 patients with IV-TPA who presented directly to our ED. So far, year to date, we've already exceeded that volume of patients treated, and we still got a good portion of the year to go. So we're definitely increasing our threshold for treating patients. Additionally, last year we received in 55 transfer of patients who received TPA at referring facilities and then transferred to us to definitive care. So we've done a lot of work around our stroke code process, and you'll see our volumes of actual stroke code activations. We are also a tertiary care facility, and we have 12 regional sites that we partner with for telestroke, where we beam our stroke neurologist into their ED if they present, stroke patients present to those partners. And we have been Joint Commission certified since 2006 and currently building towards comprehensive certification. So amongst the Target Stroke initiatives, I have them all outlined there. We do have all of these initiatives in place and active, but I'm really going to focus on this year's effort of transferring patients directly to the CT scanner, and that has really where we've seen the biggest benefit of decreasing our door-to-needle times. So you'll see here is kind of our baseline graph. In 2011, we actually implemented our ED stroke code process, and in 2012, we worked on refining that. And you'll see our baseline there, the red bar, and you'll see we're doing okay, but we still have quite a few patients who present who are to the right of that line. And we really focused on that initiative and how do we continue to decrease that down. We were doing pretty well, but we knew we needed to continue to improve. So with our direct-to-CT process, we have 5 dedicated stroke neurologists here that serve Abbott Northwestern, and most recently a new hospitalist neurologist, so he's here all the time practicing. And he took on the medical directorship for our program, and he really felt that the CT was really the major decision point factor into if we're going to give patients lytics or not. So we focused our efforts around that. So we thought, how do we get our patients to the scanner quicker? After a lot of flow diagrams and fine-tooth combing of cases of patients that we've given TPA to, this was the checklist and the process that we came up with. What you're seeing on your screen is the actual checklist that's used in our ED right now, and with great success. So you'll see there's 2 sides to this, whether the patient presents with EMS or whether they present to our triage, and we try to have consistency with no matter how the patient presents to us and somewhat of the same process. So one of the key things was through EMS, if the patient arrives on the EMS cart, we don't unload them off of the EMS cart and put them onto our beds. We actually follow the process. We arrive the patient in our electronic medical record. We arrive. We don't do a complete registration at that point. Actually arriving them, and we have the EPIC system creates the medical record for us to be able to put the order in. That prints out a name band so we can identify the patients, so we're not dealing with any of the John Doe, Jane Doe issues or unidentified patients. We don't undress the patients at that point to put them in a gown. We basically bring them back. They go into our stab room. We do a brief huddle with the ED physician, EMS, and the RN. We really look at three things. Last known well time, we confirm. We confirm that they have neuro symptoms. We confirm the blood glucose, and we confirm that their vital signs are stable. If those things are all good to go, we arrive them in the computer and we whisk them off directly to the CT scanner. Report is going on from EMS to the medic and to the doc at this time. The nurse accompanies EMS over to the CT scanner. They're put on the table and scanned. The ED tech actually follows with a weighted cart, and the EMS will then be relieved at that point to go to be returned to service if they need be. A lot of times they like to hang out in the scanner and see how the patient does. And then the patient's put from the CT scanner back onto the weighted cart and brought back to the ED at that time. There's occasional times where we'll duck off in CT holding if we think that they're going to get additional imaging. But most of the time they're returned back to the ED. At that point, that's when we focus on getting our labs. We focus on getting the additional assessment workup points. So once we have that CT, if we get that CT quick, that really is where our neurologist feels strongest about being the decision point for giving TPA. And again, you'll see that the presentation through triage on the right-hand side of your screen is very similar. We acknowledge last known well. We confirm neuro symptoms. We make sure we know what the glucose is, and we whisk them off to CT as fast as we can and back. So full registration occurs later on or with the family while the patient's in CT. So this has been a successful process for us with prioritizing the CT and then following up with labs later. This is our 2013 data. You'll see there that we do have a few outliers. And we have quality reviewed all of those. And I'll tell you, for instance, those are where we have trouble with blood pressure control or patient completely resolves. We're not going to treat them, and then they have those waxing, and then they resume neuro symptoms again. So, but the vast majority of our patients, you can see, we are well under the 60-minute mark there. So here's kind of our success, and this is the end of June data of this year. We've really pushed the larger volumes of those under the 60 minutes, as demonstrated by the red bars to the left of the blue baseline. So we're pretty proud of that work. And this slide really does a comparison of the 2 years where we've really shifted the majority of these cases well under the 60-minute mark, and we continue to push the bar on that as much as we can. So this really is the true representation of our numbers. You'll see our baseline. We started out with a median time of 64 minutes door to needle. In 2012, when we were really pushing on the stroke code process of activating the team, coordinating our efforts, following checklists, we got down to 52 minutes. With us expediting this door to CT as our primary point, we've really dropped our median time down to 46 minutes. So I'm thrilled every time I review a case that's in the teens, or 26 minutes seems to be a popular number lately. So it's working pretty well for us. We do meet monthly as a multidisciplinary group to review each of these cases, especially those that we gave TPA to or those that we called a stroke code on. And we just review each checkpoint in time through the process of that patient from when they hit our door to when we actually treat them. We've expanded this beyond IV TPA, and we're starting to look at our patients that go to intervention and those in-house stroke codes also that we're really trying to focus on bringing that acute stroke treatment time down. So what are our lessons learned? Our lessons learned is that communication is key. We really have to make sure that everybody's talking to each other. EMS pre-notification, I have the 3 pauses there because in a metro care facility, this almost causes us a little bit of a hiccup. We'll get a call from EMS that they're 10 minutes out with a stroke patient, last known well of 40 minutes. Our team arrives and they're huddled around our stab room, and we wait for 10 minutes. We wait for 10 minutes. Our ER is often at capacity and very busy, so for staff to just stand there and wait for 10 minutes for the patient to arrive doesn't work very well, so then they often go off and do one quick thing, so then we've had trouble reconvening the team. So we've put a little less emphasis on EMS pre-notification because we're almost better when we don't get that pre-notification. And I know that's the complete opposite, but really for a very busy metropolitan ER that's always touching capacity, it's better if we pull the trigger and go. So it really is EMS pre-notification. It's hard to tell a time of day if they get stuck in traffic or if they're not as close as they thought they were. And then also EMS pre-notification too for those patients who get flown into us or we receive as transfers from some of our referral facilities. So relationship with EMS is always huge. You know, what we have as expectations of them, of identifying a last known well, we have a cutoff point of 6 hours right now. Trusting in their vital signs and them having a glucose done for us and having a line in when they come to us. Because if the patient is reported to have a normal glucose and their vitals are stable, we don't stop and reassess that. We bring them right to the scanner and then confirm or just resume our checks when they get back. Consistent process, I mentioned that briefly. No matter how the patient presents, we really need to have the flow as similar as we can so that each of these patients are getting processed and the acute treatment activation kind of goes off the same way each time. Consistency with our checklist. The checklist I had on the screen earlier, we realized that, you know, if we omit a step here or there, you know, pharmacy doesn't get involved in the process, or if we miss confirming that the lab needs to be drawn now, or if we miss that communication, or we miss arriving the patient and they get over to CT and the arrival hasn't been done yet, then we have a little stalls in the process. So when we follow the checklist, the process works well. We need to ensure that the weight gets entered. So we have had pharmacy premix the TPA, but they can't dose it without a weight. So even though we have a patient on the weight cart, we still have to get that entered into the electronic medical record so pharmacy can dose the drug. The TPA drop-off point, as I mentioned briefly, sometimes those patients will go to CT holding for additional imaging, or they'll stay on the CT table again for additional imaging. So where that patient goes and where pharmacy needs to deliver that med to can sometimes change. So we've worked on some key drop-off points for the TPA. And then follow up with lab results. Sometimes it's hard for our lab people to, this was a little bit of a flip for us with this process. Initially, we would go in and we get those labs right away so we could process them while the patient was in CT. Well, with some of the changes in the guidelines, we felt that the CT was much more timely sensitive. So we're actually having the lab come in after the CT is done. So it's our lab technicians being on the ball to come back and check on that patient after the stroke code process has been initiated. And then the timeline case reviews. It's really our way to give feedback to the ED, to give feedback to the providers, to let the staff know how well they're doing. This has been a relatively new process for us since we started working on it in Q1 of getting it set up and built, so there was already an increased awareness, but the official go-live was in the beginning of May. So to allow for a test of change period to see how the process pans out and allow us to fine-tune what we've set in place and then really reevaluate. So that's what we have from a metropolitan perspective. So turn it over to Katie, I'm assuming.
Yes, thank you, Karen. Before we open up for questions, I would like to share just a few slides on how you can register and earn target stroke recognition for your organization. The first step in learning more about our Target Stroke Initiative is logging on to our website and registering your stroke program. Registration involves a 10 to 15-minute survey on your current stroke program and is at no cost to you. It then allows you to access our tools and resources to help you make improvements with your door-to-needle efforts, along with ensuring that you receive emails on upcoming Target Stroke events. This slide lists the requirements for a site that wishes to achieve Target Stroke recognition. Any site wishing to be recognized at a Target Stroke hospital will need to be entering data into Get With the Guidelines and have an active bronze, silver, or gold award. More details and information, you can please access the Frequently Asked Questions document, which is available for download along with a copy of the current Target Stroke application form. Your local QI representative will be happy to help you review your data to determine eligibility for Target Stroke recognition. And finally, Target Stroke hospitals are recognized on our public online quality map, our annual edition of U.S. News and World Report, Get With the Guidelines edition, and are provided marketing tools and logos to help promote their award within their communities. I have listed the websites here so you can access that information as well. With that, I would like to thank you for attending today's Midwest Affiliate Target Stroke webinar. This last slide provides the contact information for your local Quality Improvement Director that would be happy to work with you on Target Stroke. We will now open the phone lines up for questions. Please note that you can also type your questions into the Q&A box. Operator, can you please open the phone lines?
Thank you. We will now begin the question and answer session. If you'd like to ask questions, please press star and then 1, and please record your name clearly when prompted. To withdraw your request, please press star and then 2. One moment, please, for the first question. Once again, to ask questions, please press star and then 1, and please record your name clearly when prompted. At this time, we have no questions on queue.
It looks like we have
in the Q&A section that I could probably share.
Yep, go ahead.
One asks, do you get the family to consent before giving TPA?
This is Geralyn. I can say at our facility, if we are within the 3-hour window, we consider that standard practice, so we do not get consent. But if we are outside of the FDA-approved window of time, we do get consent.
Thank you.
This is Karen, and we also do not require consent for TPA. We feel that from the FDA approval trials and what is supported in the guidelines, it is a standard of care.
And this is Kathleen ONeill. I can speak on behalf of my 15 hospitals in the city of Chicago. This was something that was discussed quite at length at one of their collaborative meetings. And we had hospitals, some hospitals that still had very long legal documents for TPA consent. And then we had several hospitals that, as long as it was in the 3-hour window, were doing no consent at all. And what we actually have been working on together are just talking points and ways that we can help expedite the communication of the consent for the patient and or family, and that's been of great help. So I think, we've kind of helped some of the hospitals who had been using a consent form to kind of move away from that and share some of these other shared resources. So.
Thank you. Another question. Are you drawing any labs before TPA administration?
the hospitals want to answer that?
Yep, this is Karen from Abbott Northwestern. And yes, we are drawing labs before TPA administration. Typically, we go directly to CT, get that done, and when the patient finishes their CT, at that point, we actually draw the labs. We don't necessarily wait for all the results before we start it. I will tell you that we've probably had 3 cases where we've started TPA and then gotten lab results back and then have actually stopped the infusion with no adverse effects. You know, that's something that we'll have to dig in and study a little bit, but that is supported in the guidelines also.
This is Geralyn. We basically do the same thing. We are usually able, the nurses will draw labs in the ER prior to the patient going to CT scan, and they can run iStats in the ER. But kind of the same thing, we do not always wait for lab results prior to giving TPA.
Thank you. Okay, there's another question. Is the TPA mixture always being mixed in the pharmacy?
This is Karen, and I can answer that yes, and that is kind of a hospital regulatory issue that we've, you know, talked about and discussed multiple times, but our pharmacists have been successful with mixing it and getting it where we need to go. We are, however, resourced with a pharmacist actually in our ED, except for a brief period at night. And again, like I said, as soon as they get the stroke code page, they usually call and confirm, do we think, you know, what was last and well, do we think we're going to mix? They'll get the yes and they'll mix it, but they don't always dose it. I'm going to kind of roll that into the next question that I see on there. So TPA will get mixed, but not always dosed for the patient. And we don't have any problems with waste here. We can, you know, break it down and use it for other purposes, or we can, we have had wonderful results with reimbursement from the pharmaceutical company also. So we haven't had really any misses. And I'll tell you that our patient selection has really fine-tuned, and the majority of the time when we mix it, we almost always give it.
Okay, thank you. Okay, the next question is, what is your process for real-time tracking and case review feedback?
This is Geralyn. I review the cases ongoing, and actually as soon as we have a case, and actually they're doing a case right now in the ER as we speak. So Dr. Hopf and I will go down there, look through the case, and actually, you know, provide feedback. I usually try and do that within the day of or the following day, minus the weekends. But I usually try and provide that feedback almost immediately to the staff, and then start looking at the process and how we can improve upon it.
And this is Karen, and with our stroke code page group, I get a page for every stroke code that happens, and I am oftentimes present at the stroke code, so I'll follow the patient through the process, and by the time we get settled in the ICU or through treatment, I usually loop all the way back directly with the staff that were involved. If not, I review. If it happens on an off shift when I'm not here, I'll look at it the next morning, and then I'll follow it back. We're actually looking at a case review format where we can de-identify and direct. We do also share the results of what I shared with you today, how we're doing with door-to-needle times overall with the leadership across the hospital and directly with the staff also.
Thank you. We have a number of questions regarding how to get copies of the presentation. If you look at your screen on the top right-hand side, there's 3 papers. Those are your downloads and handouts available for this presentation.
Yep, and actually, this is Katie. We can send out a copy of those slides once we just get confirmation from all of the speakers. It doesn't look like we have them listed to download. And I would like to make another announcement as well. Listed with the email addresses, we have one that needs to be updated. For our Indiana participants, it's actually going to be gregory.po@heart.org, so GREGORY.po.
Sean, are there any questions via the phone line?
Ma'am, we have a question on queue right here, and it's coming from Ms. Terry Hansen. Ma'am, I'll open up your line now.
It's open. Yes, can you hear me?
Yes.
Okay. Yes, Carrie Hansen here from Wheaton Franciscan Healthcare, St. Francis Hospital in Milwaukee, Wisconsin. At what point do you get your actual health history on the patient, surgical history? Or do you not count that into your time frame?
For determining TPA.
For determining TPA, yes.
Oh, well, this is Karen from Abbott, and I will tell you that usually that we are extremely fortunate to have the 5 stroke neurologists here who support our program, and they're almost always there within 10 minutes, especially during the daytime. Most often the stroke neurologist meets the patient down in the CT scanner because the ER gets them over to the scanner so fast. And then with the electronic medical record, it's easy to pull those patients up and look through their history that's in there, and then also get it from the family or the ED provider or EMS that's there. So either the stroke neurologist, as soon as he arrives, gets that, or he gets the report from the ED provider who has populated that. You know, because although we get the CT scan and decisions being made, they are still mixing the TPA. So, and we do have kind of that safety confirmation that, yep, do we think this is. One other thing that I would say that our stroke neurologists are extremely good about is, and we've had this happen a few times with in-house stroke codes, is that, you know, if it's a recent kind of minor surgery, they will literally dial up the surgeon and let them know we have an acute stroke, time sensitive, and, you know, have that conversation. Is it safe to give these patients TPA? Do you think it's okay following your surgical procedure? So electronic medical record has helped immensely with that. And for those that we don't have, we really have to go off the history that's available at the time that they present. So,
thank you.
Once again, to ask questions, please press star and then 1, and please record your name clearly.
Pam, are there any other questions coming in by via web?
Yes, there's one, and I'm not sure if anybody's going to be able to answer this or not. It's specific to EPIC, and they want to know, how do you ensure compliance with TPA protocol, vital signs, and neuro checks using EPIC? Do you use TPA paper tracker or document in EMR?
This is Karen, and I can answer that because although I probably have referred to it as Excelian, that's Elena's brand for the EPIC product that we use. And so ensuring vital signs, we actually have a TPA flow sheet that's used, and that transfers all the way across. And yes, we are completely electronic. And that has the fields of the combined neurochecks that we require and the vital signs. So they really are going to one flow sheet and clicking. It also has a point for transition of care with the mutual neuro and the handoff for that time consistency. Part of our work that we're starting to dig into now is follow up with EMS to make sure that when patients get TPA in one of our referring facilities, that EMS is continuing because they're critical that that gets done en route to our facility and then handed off to our nurses so that we can continue to make sure we don't have a gap in that.
Great. Thank you, Karen. And there's one more question I have here. How did you get buy-in from EMS to stay with patient and bring weight cart to the CT and not just leave?
Well, number one, so let me clarify that a little bit. How did we get buy-in from EMS? Well, we did send out a memo to all of our EMS services, and there's a lot of EMS services that transport into us being a large metropolitan facility. So we sent out a memo for them, and basically we updated them that we're going to do this because our CT scanner is also not located in our ED. We have to go out across the hallway to it. So we do a quick pit stop and say, no, we're going to leave them on the cart and bring them right over to the CT scanner. And then we release them from there. So we don't hold their cart up and we don't hold up the crews. We actually just ask them to go to a drop-off to do a quick pit stop huddle, which literally takes a minute, and then to do a drop-off point probably, another 20, 30 feet down the hallway. And then we have our ED techs who bring the weight cart to the CT scanner to pick up. So it's not the EMS crews itself, it's our ED tech staff that bring the weight cart over. And what we find actually is EMS actually loves this because they get to see, number one, that we're treating this stroke patient with a sense of urgency, that we really are getting them through to care. EMS really likes to watch the scan and see how things progress, and it's been really well received and a lot of positive feedback from our EMS crews.
Thank you. I have no more questions.
Operator, are there any more questions coming in on the phone line?
Yes, ma'am. We have one question on queue, and this is coming from the line of Ms. Mary Lou Mitchell. Ma'am, your line's now open.
Hello?
Hi.
Hi, this is Mary Lou Mitchell. I actually had my question asked for the EMR for the TPA vital signs.
Yes, this time we have no questions on queue.
Karen, can you speak to how do you ensure compliance with the TPA protocol with respect to vital signs using Epic? Are they all electronic?
They are all electronic. We built a flow sheet so that if a patient has received TPA, they can go to one spot. And where staff really likes it is it's a combined flow sheet that actually has the vital signs frequency, the mutual neuro handoff, the check box, and those required components for the neuro checks. They just go to one flow sheet to document handoff, mutual neuro, the vital signs required, and the neuro checks required. So no matter if they're in the ED, the ICU, procedure, they are on one flow sheet in Epic that they document.
Great. Thank you. With that, we are at the top of the hour, so if you have any further questions, please feel free to reach out to your QI director listed here. We will be sending out a follow-up email with a recorded link and the slides whenever we get them. So with that, I thank you for attending our webinar this afternoon. Everyone have a great rest of your day.
That concludes today's conference. Thank you for participating. You may now disconnect.